Ian, of course, doesn't need any introductions to the people right in front, but some of those further back. So Ian Cotgreave is from London, as you can hear from his accent.
Wow.
No, actually north of London.
Yeah.
England, actually.
North of England, yeah, but I train in London, yeah.
North of England. Trained in London. He's now at the Karolinska Institute. Been there for 18 years, you know.
That's right.
Yeah, correctly. And he's a world authority on what he's going to talk about, which is, I didn't realize that you were an authority on clinical practice, but on redox and sulfur compounds and toxicology is really the specific field that Ian is an expert in. And it was very nice visiting him there recently, where he told me a lot about toxicology. And I guess most of your audience that's going to be here on time is here. And so we'll have you start. I guess that's the title. Everybody free. So, thank you. It's a pleasure to have you here at the Beckman Center.
It's my pleasure to be here as well. Well, you know, you can sit here in this, you can sit on the other side or there or whatever. But yes, thanks, Len, for the introduction. World-renowned figure, I'm not so sure. I'm a kind of a master of nothing, but I know a little bit about most things, and that's been my training, my background. I do work in the toxicology department, but all through my life as a pharmacologist, toxicologist, biochemist, I've tried to deal with clinically relevant situations. And today I'm going to talk to you about a little bit of precautionary words. These are precautionary words to people who are considering using drugs that contain sulfhydryl groups and sulfur in clinical practice. And there's some, I'm going to illustrate the caution with a few simple examples of how basic cell biology can actually guide, can explain sometimes the effects you see in clinical practice, and can also guide your choice when you're considering novel therapies or adapting existing therapies. So I'm advocating for sound cell biology and biochemistry at the bottom of things to make sure that you really are indicating a clinical therapy based on logic. And we're dealing, of course, with amino acid supplementation, chemicals that look like sulfur-containing amino acids in drug therapy. So that's the title. And by the way, despite the suit, I'm extremely pleased to be here, but I'm extremely informal as a character. So you don't understand something I'm saying, put your hand up and I'll leave the room, all right? Then I'll come back again when I quieten down, and we'll answer the question. Okay. Just as a basic introduction to the field and what we've been discussing in this meeting for the last couple of days, here are a few cases of disease states where glutathione, which is a central character in biological redox, and the functions of glutathione are manifold, but in this case we're primarily interested in the role of glutathione as an antioxidant and also in its regulation of protein function, but I won't go too much into that. Primarily, it's a good thing because it keeps the normal redox balance in your cells in a reduced state in the face of the onslaught of molecular oxygen and all of its buddies, which we have to live with, unfortunately. But in certain disease states, it's quite clear that glutathione deficiency arises and is associated with the pathology, whether it's causative, whether it's chicken or egg, doesn't matter. And this is the most world-famous of them all. Of course, this is Tylenol, paracetamol toxicity in patients who are trying to take their lives. And it occurs quite frequently still in Sweden. We have about 300 attempt suicides in Sweden a year, and about 20 to 30 of them are successful. And one of the major signs and symptoms is hepatic necrosis mixed with apoptosis, and basically to do with an increased burden on glutathione pools and a reactivity with sulfur-containing components on proteins or something. But it's a well-known example. In inflammatory diseases, particularly in the pulmonary tract, there have been a number of observations of glutathione insufficiency or depletion in certain cell types during hyperbaric oxygen treatment, which is sometimes indicated in patients, and it's quite a tricky affair. particularly if you have hypersensitivity in your patients and so on and so forth. Where bronchial epithelial cells, vascular endothelial cells, and smooth muscle cells become the target and in fact suffer the glutathione depletion and are exposed to an abnormal redox situation because of that. One of the central issues for the meeting that we're holding today and yesterday was, of course, the work done here at Stanford by Len and Lee, among others, on HIV and the systemic depletion of thiol-containing amino acids and glutathione, particularly in certain lymphocytic types that you see as a marker of the disease. And yes?
About the hyperbaric oxygen treatment.
Yes?
Sorry, Jeff, yeah, you can see here. Does the damage happen in the upper
in the proximal airways?
In the proximal airways, okay. So is there any other...
It depends. If you go to extremes of, extremely extended oxygen therapy, you can get way out in the periphery. You can get edema, but the first signs of a reaction to hyperbaric oxygen occur in the proximal airways. I'm not the expert there. My pulmonary physician friends will tell me more about that. And that depends on whether it's young or old patients and other things involved in that. And also a group of diseases and situations which are not often considered to be associated with this kind of problem. But, sorry, you're having to look through me, all right? I can stand back here like that. Is it all right, Len?
No, I'm all right.
Okay.
I can see the back of you.
All right, good. Is the situation that occurs in the body during systemic trauma. And this is everything from post-operative shock syndrome, put a patient on its back after removing a pimple from its nose, or you take off or remove the pancreas from a patient. You get some degree of post-operative trauma, which results in muscle wastage. And if you look closely at the muscle in the atrophy, you have massive drainage of glutathione going on in there. And I'll talk to you in reasonable depth at the end of that on that special case, which is a speciality of mine. Despite I'm being a toxicologist, I work with both post-operative trauma and also with sportsmen, elite sportsmen, and the things that they have to deal with in their bodies. And hopefully getting into spacemen one day, because they do come out of space and they can't stand up because of atrophy. Yes?
If I could ask a simplistic question.
Sure.
Are you talking about the balance between reduced and oxidized glutathione, or actually disappearance of glutathione?
Well, of course, as soon as you shift the level of reduced glutathione, you're going to affect most other redox couples that are associated with that. But for this instance, let's call it total glutathione in the tissue. Okay? But that's an important point. We'll come back to it later on. I'm sure Dean Jones will also have things to say on that. So this is setting the stage. These are the kinds of disease states that we're dealing with. And the list is long, and it's getting longer all the time. And in fact, we are writing a review article where the numbers of diseases where glutathione deficiency, the idiosyncratic observations, are increasing by the year, by the day even. And the reasons for that may be commonality in the mechanism driving the pathologies, in oxidative stress, which is an important word to understand here. Now, we have a number of endogenous amino acids that we get from our diet primarily, which is used to make or to supply the sulfur demand for our body. Every protein contains sulfur. Glutathione requires sulfur. We have a lot of intermediary chemicals, small molecules, that contain sulfur. And therefore, we have to take it in the diet. And there are a lot of amino acids and peptides, which are the primary source. And of course, the amino acid cysteine and its oxidized form cysteine are important sources of dietary cysteine. Okay, so those are the two things that spring to mind, just to get you familiar with the words. Methionine, of course, an important amino acid, also a sulfur precursor for our body, which is important to think about. Glutathione as a tripeptide itself, a great debate on whether dietary supplementation of glutathione is also a sulfur donor. Particularly, Dean has done plenty of work in the area, other people there as well. And whether systemic glutathione serves as a sulfur pool for various organs around the body, it's a current bone of contention. But it has to be included here. It's It's a peptide, and its oxidized form as well. Homocysteine also, we had a wonderful illustration of that, and we'll get some more from you tomorrow on this aspect. But homocysteine must be considered as a primary source of cysteine in the body as well, or sulfur in the body as well. So, there are plenty of endogenous molecules to think about. Nature is full of the raw materials that we need to make sulfur-containing biochemicals in our body, amongst them glutathione. But we've had an interest also to develop chemicals, xenobitoics, foreign chemicals, that will serve as sulfur donors in a controlled manner by controlled pharmaceutical delivery. And the list is not as long as you would imagine. And there are a few favorite compounds of interest. Most of them are based around the cysteine structure itself. So they are derivatives of cysteine, closely related analogues of cysteine. And the ones that are commonly used include oxythiazolidine carboxylate, the glutathione esters. And now these are esters of glutathione which were developed by Meister, Alton Meister. There are mono and di esters here. These guys are cleaved directly by non-specific esterases to release the actual molecule glutathione. The perfect answer. Alton Meister pushed these for years. But it's not that easy. The absorption of the molecule into the cell isn't an easy process. Not all cells can use glutathione esters. And in fact, glutathione esters have some toxicity problems which are not generally talked about. Cysteine esters and dipeptides. There have been a great interest pharmaceutically to develop complicated molecules for delivering cysteine as dipeptides, putting a handle on them, which makes them more both stable as a molecule, because cysteine is a fairly redox reactive chemical, and also putting a handle on them so that when they swish by in the circulation, you may be picked up by a specific site in the circulation. So there's a great deal of interest being put into these kinds of molecules. And a molecule which we'll hear again about tomorrow, which I included here in the xenobiotic group, but really it's not strictly true, but it is, if you like, a drug principle as well as being an endogenous molecule, S-adenosyl methionine, which we'll hear more about tomorrow. However, the talk today primarily centers around this molecule, okay? And there was no sound, and I was just going to drop a bomb in here. And N-acetylcysteine, which, to my knowledge, is the sulfur donor, the xenobiotic sulfur donor, which has been studied the most and which has been shown to have clinical effects in a wide variety of disease states where glutathione deficiency is associated with the progression of the pathology. So N-acetylcysteine, for our purposes, is perhaps the xenobiotic molecule number one to think about when talking about glutathione replenishment therapy with xenobiotics. And just to get you in the mood, I'm going to give you a few of the characteristics of this molecule as a chemical. And it's something that we should remember. Yes, N-acetylcysteine is a cysteine donor. The word itself tells you that it is a cysteine donor. To deacetylate it, bingo, you've got cysteine there. But this carries with it a need for obligate deacetylation. So you need metabolic cleavage of the molecule, okay? That's the thing to remember. So it just doesn't fall apart in the body. Yes, it's redox active. And that carries with it, because it is a sulfur redox couple, sulfhydryl redox couple, carries with it some special considerations that you should never forget, which also glutathione and other sulfhydryls have. It auto-oxidizes. So with molecular oxygen, it will generate superoxide radical anion quite happily for you in open solution. And this is a concentration-dependent thing. So cysteine is at high concentrations, above 300-400 micromolar, we can argue about the concentration, is a nasty redox-active chemical that will kill cells. in the interval window in the circulation where cysteine is lying at 4, 5, 6 micromolar, you can argue about that, then it's not a problem. Put 400 micromolar on red cells, lysis, within an hour.
But not NAC.
NAC will do that at very high concentrations.
20 millimolar.
Something like that. So the autooxidation tendency increases as you go down to cysteine by an order of magnitude or 2. So this is a lot safer a molecule than cysteine itself, which is one of the arguments we raised today in the meeting. It's cysteine thiol in the thiolate anion form, and it's ionized quite readily at physiological pH, reacts, because it is a nucleophile, reacts with electrophiles. And this is the classic reaction in Tylenol. This is the reactive intermediate that's generated in Tylenol. N-acetyl parabenzoquinone imine, a very reactive electrophilic chemical that if you don't mop it up with glutathione, it spends its time reacting with protein thiols and disturbing function. It's its toxicological basis. Yes, it reacts with peroxides and very reactive free radicals, but the reaction, the chemical reaction with peroxides is surprisingly slow. So this is not really a very good antioxidant, which is a classic mistake you make with N-acetylcysteine. The basal reaction rate between hydrogen peroxide and N-acetylcysteine is pretty slow. And of course, we don't have enzymes to catalyze that, such as glutathione peroxidase. I spent 10 years developing chemicals based on selenium redox chemistry that would actually take N-acetylcysteine as a thiol donor, chemicals such as Epsilon, which you may have heard of or not, and reduce peroxides catalytically. So you can play tricks pharmaceutically with N-acetylcysteine and peroxides. N-acetylcysteine won't react with superoxide radical anion because superoxide radical anion is not a very good oxidant. It's a reductant, more in the physiological sense. Yes, it reacts with reactive oxygen species, but slowly. As a scavenger, you have to have very high concentrations. Importantly, because of its thiolate anion form, it will interchange with existing disulfides and perform thiol disulfide exchange reactions. And that can be N-acetylcysteine reacting with cysteine, with GSSG, with protein, glutathione, mixed disulfides. Depending on the concentrations of the reactants, the equilibria will be struck. And this plays an important role in the disposition of the compound when you squirt it in the arm of a patient. It doesn't remain free for very long. It tends to move to oxidized forms, being bound to protein. That's an important pharmaceutical aspect, yes?
But an important point is, as far as it's known, it does not function in any acetylation reactions. I mean,
No.
there is no transfer of that acetyl group, just simple
I've
hydrolysis.
never read of an acetyl transfer, as not like aspirin. It will not do that, for it's not chemically labile, as is acetyl salicylic acid, particularly.
And most of these, or maybe all of these chemical reactions you got listed there, how much of them do occur physiologically?
Well, I'm trying to put a little bit of bias on. I mean, the autooxidation reaction is slow. Its reaction with N-acetyl parabenzoquinone is fast. This is a fast reaction. But in the liver, when you give N-acetylcysteine against Tylenol poisoning, this is unimportant because it's the glutathione that's the important thing. Right, so its reaction with peroxides and, well, hydroxyl radical will react with anything, so this will react with hydroxyl radical, but with peroxides it's pretty slow. I'm getting it over to you that this is not a very interesting molecule when it comes to redox reactions.
And it's not interesting in part because it disappears very rapidly.
So, yes, of course it does, but one of the aspects is that it's supporting a molecule which biology has designed to be fairly effective at doing what we want it to.
Sure, glutathione, but I'm trying to understand from your point of view, from your knowledge, maybe others, how much of the action of NAC and acetylcysteine is as NAC as opposed to...
We'll come back to that point in the first example that I'm going to show you. Yes?
So if you're using N-acetylcysteine as a glutathione-bearing cell systems, what sort of concentrations would you expect it to be toxic? Because many investigators have used it at concentrations in the region of
30, 40 millimolar. It's totally ridiculous. I mean, but it's not toxic in the sense that if you're looking at an apoptotic parameter or you're looking at a progression to necrosis, if you look long enough, sure. I mean, you might just run the thing out of reducing equivalence. You might
It can be toxic from the release of the acetate. You can, when you go to 20 and 30 millimolar acetate,
if there's
some
an active
cells,
deacetylase.
yeah, some cells can't tolerate
Some
that.
cells can't use N-acetylcysteine, and we'll come back to that in a while.
We actually found some of that toxicity was just salt toxicity.
Yeah.
You got up to molarities that just weren't happy. The cells weren't
Cells
happy.
can't handle it.
Yeah.
Okay, the last bit is immaterial here. Now, these are just a few of my visions of what important concepts of governing systemic manipulation of tissue and cell glutathione in disease are. These are things that one should consider when setting about starting a therapy. And they are my own opinion. The first question I would like to ask is the availability of cysteine in the site alone rate limiting? That's an important question. It sounds trivial. But we always assume that cysteine is the rate limiting factor. But in some cases, such as systemic trauma, the muscle tissue will actually drain of other amino acids that are important for glutathione biosynthesis. Glutamic acid, and so on and so forth. There are other effects to consider, but often we do say that cysteine is the rate limiting factor, and therefore support of cysteine is indicated directly. As a clinician, you're not interested in this. Basically, you're interested in effect in your patient, whether you get a treatment, a therapeutic effect. But is the depletion you're looking at a cause or a consequence of the disease? Semantic argument. But for me, as a mechanistic kind of person who doesn't have to deal with patients all the day, then this is an important question to be answered often. Cause or consequence, chicken or egg? Either way, which compound should we use to manipulate this? Should we use an endogen, where the tracks are laid down for the trains to run on in our bodies? Nature has designed the tracks and the switches and the signals and the stations. Or should we use a xenobiotic? And if we use a xenobiotic, what kind of xenobiotic should we use?
What is a xenobiotic? Could you define it briefly?
Xenobiotic is a non-natural substance, a man-made substance that would not normally be associated with physiological systems.
Foreign to life.
Foreign to life, xenobiotic. So, the decision must be based on, and this is classical indication, based on pharmacokinetic and metabolic data governing the compound in the body like any other drug. Now, this is something that we often forget when we're dealing with N-acetylcysteine, but this is in fact built into the use of most therapeutic compounds. We have to consider this. One important concept which is not always considered is the parent compound and or sulfur-containing metabolites, because often we are dealing with a potpourri of metabolites that emanate, for instance with NAC, emanate from the central molecule. Bioavailable, in this sense, not oral bioavailability, but microbioavailability at the site desired, at the desired site of pharmacodynamic action. So that's to say, if you're wanting to treat the pulmonary epithelium with an oral dose of something, does the material get to the site of action and manipulate the parameter you're interested in? So you have systemic metabolism to think about here, and you have specific uptake processes of parent compound and or metabolites to think about. And this is where I'm going to spend my time talking today, on some simple, very simple biological experiments with different cell types to illustrate the role with which specific uptake processes for amino acid precursor glutathione biosynthesis on the sulfur side can actually dominate the situation. And it's something one should think about when deciding which compounds to use in therapy. Case 1. It's quite clear that, for instance, in treatment of certain cases of certain types of diseases with high oxygen tension or during a disease such as ARDS, that endothelial injury occurs quite quickly, and that is associated with the induction of oxidative stress in the endothelial bed. And many measurements have shown that the antioxidant capacity of these cells in situ are compromised very quickly by the situation. It's a direct effect. And there have been a number of studies using, for instance, N-acetylcysteine infusion in model animal studies and also in patients, showing that you can actually quite convincingly protect the endothelial bed and the ensuing edema, perhaps not in ARDS as clear, but certainly in high oxygen therapy with N-acetylcysteine. But there is very little understood about how the N-acetylcysteine worked. Now, these are anecdotal studies I'm going to show you. Some of them are very old, but they illustrate the point. And in this case, the data is nearly 10 years old. And I wondered, for instance, how do human endothelial cells synthesize glutathione? It's a straightforward question, and I couldn't get it from the literature at that point. So what do? Well, and also, of course, can NAC be utilized for glutathione replenishment in these cells when you deplete them? And how would this NAC or glutathione be protective in the endothelial cells? It's a standard question. And in order to do this, I chose a model endothelial cell system. And this is not pulmonary endothelial cells, but we've tried this with other kinds of endothelial cells, and it's a fairly similar effect. And one of the ways to study glutathione replenishment that we adopted was that we wanted to deplete them first. The situation is kind of akin to what you might see in the disease state, that you get a depletion of glutathione. And here we don't do it by pouring electrophilic compounds on to the cells. We actually put them in a medium which is devoid of sulfur amino acids. And you will see this appearing continuously now in my lecture. It's a medium which is devoid of cysteine and cysteine and methionine. In essence, you're putting the cells in a situation of quiescence for a short period of time. And you see slowly that the cells deplete their glutathione. And this is quite a common trend or kinetic that within 12 hours, this has a half-life, a turnover of about 6 hours, 4 to 6 hours. If you did this with BSO, you get a very similar kinetic. Okay. Within 24 hours, you're down to 75% depletion. And you can use the cells at this point. The interesting thing is then you have this medium which is devoid of sulfur amino acids, which you can then feed back the amino acids one by one and study the specificity of uptake. And here are just a few examples. So we see at this point, where they are depleted by the treatment you saw, we can then add back various things to the medium. This is just untreated cells, and they remain depleted for a further 24 hours. The expression of this robust glutathione level could well be mitochondrial glutathione in the cells, which is known to survive longest. Now, various manipulations here. We have the addition of plasma that is weathered and been stored around in the building for a while. We have the addition of, let's see, this is fresh plasma here. You can see the difference. These cells, being endothelial cells, are normally exposed to plasma. So it was quite an easy experiment to do here. This is the exposure to frozen bank serum. And this is the exposure to control M199 medium. And this is the normal level of glutathione that you see in the control cells. So you get this classic shoot-over effect due to delayed feedback inhibition of glutathione synthesis. But I just want you to see that using various types of body fluids and medium, you can see that you get the glutathione back. So the synthetic capacity is intact in these cells, okay? Yeah.
Does that replenish mitochondrial GSH as well as the cytosolic, or just cytosolic?
Well, the interaction between the cytosolic and the mitochondrial pools of glutathione, there are established mechanisms for that. And if you, and I did mention that the mitochondrial pool is considered robust. You have a better idea of that than I. I've never worked with a specific mitochondrial pool. Yeah.
It probably would do because of high affinity transport
Yeah,
in the
exactly.
mitochondrial membrane.
Exactly.
Which
So you reflect, but in a way you reflect, when you do something in the cytosol, you reflect. And the interesting thing is also we're working with the nucleus, looking at the control of the nuclear pool of glutathione. And that's an interesting thing as well to come back
So
to.
when you get replenishment, can you say whether you get equal replenishment in the three pools, cytoplasmic?
These data are just, these are done with bromobiamine, so they're the intact cellular glutathione pool. So there's no differentiation whatsoever here. All I do say is it's very difficult to deplete these cells. The longer you go, this is 18 hours, you go 40 hours, it's still fairly stable at a very low level, and that could well be the mitochondrial pool. Okay.
And that very low level is, what is that, like 5 millimolar or something?
But if you consider the concentration here in the control situation is between 3.5 to 4.5 millimolar in endothelial cells. But you're looking at, you know, maybe 0.5 millimolar here left in the cell. Yes?
I've just recently been performing some experiments and I've found that the cytosolic pool seems to be depleted when used BSO, that is, in about 24 hours. And about at 48 hours, the mitochondrial pool seems to be depleted, which occurs subsequent to increased ROS production. So I think the mitochondrial pool is much more stable.
It's robust. Yeah, I mean that's the general gen of things. And Meister was clear to point that out many years ago, and Dean has done work there as well.
I didn't hear. What about the nuclear pool?
Nobody knows. You give me 2 years to do that, and I'll come back and tell you.
And what kind of cells are you referring to?
I was using that cell on PW.
Yes, you have a question.
Well, you wouldn't propose that these cells are necessarily representative of cells in an inflammatory state, because on the one hand, you've depleted the glutathione by nutritional and turnover, whereas in the inflammatory state, you've got an incredible array of cell mediators, inflammatory mediators.
Absolutely. All I'm saying is this is basal cellular. I'm trying to illustrate a point here using a simple approach, that trying to find out the precursor specificity helps you perhaps to decide which compounds to use in vivo. And I quite agree with you in the sense that how the depletion is occurred, these cells, when they're exposed to cytokines, when they're exposed to granulocytes creeping along their surface, producing reactive oxygen species, trying to squeeze their way through, shear stress, the whole lot. I understand what you're saying, but this is just a very simple experiment, very naive experiment.
I'm bringing it up just because it's a huge dilemma when you confront experimental or clinical approaches that presumably are going to address glutathione replacement without taking into consideration some of these inflammatory mediators.
Well, imagine that
actually are working at a transcriptional level and probably independent.
the fundamental issue here is does the specificity of uptake, and this is cysteine-dependent replenishment, and these are the levels of free cysteine, quite uniquely high levels of free cysteine, which occur in the cells, are tolerated by the cells during cysteine-supported resynthesis. Now, when you go through the repertoire of amino acids that will do this for you, will that change in the actual pathological situation? That's an important question. And I will address not that question, but another important question when it comes to doing cell culture experiments, the state of differentiation of your model as well, which is also an important thing which people forget about. And I'll come back to that in the end.
These
Yeah.
numbers are remarkably high for cysteine.
Exactly.
Looked at cysteine in 15 different cell types, and there's nowhere near that amount of cysteine.
Endothelial cells are peculiar for many aspects. They sustain these high levels of cysteine. And what you're dealing with, I mean, this is 5 micromolar cysteine resupplied. Cysteine, 40 micromolar, 25 micromolar in the circulation. This is the kind of kinetics you get from 25 micromolar. But these levels here were remarkable and they were reproducible. This was done with the bromobiamine assay, and so cysteine was captured. We even did a mass spectrometry analysis to show that that was cysteine and not something coming out of the reagent. And endothelial cells will also sustain a high degree of protein glutathionylation in comparison to all other cell types that I've ever looked at. So endothelial cells have some peculiarities about their sulfur biochemistry, which has something to do with their ontogeny.
And you did confirm this was all cellular rather than just in the total medium.
This is cellular.
So,
Oh, yeah.
How would you explain that it would finish up to twofold the
Again, glutathione synthesis is feedback inhibited by its own molecule, but it takes a while. It's a pretty sluggish procedure in endothelial cells, but I'll show you for instance, in muscle cells, when I come to that the procedure is a lot more tightly regulated. You very rarely see this kind of overshoot, but liver cells will do this for you as well, and that's fairly old biochemistry, the feedback inhibition.
That's 12 hours, you would level down to...
Yeah, right, until you run out of your precursors. I mean, here, for instance, you seem to be heading back down again. And this is quite common. You'll see graphs like this. When you're burning up the amount of cysteine that's present in the medium, you're using it, and of course all the time you're turning over glutathione, because these are aerobic cells. They have metabolism. Okay, we'll hop over that. Now, of course, I was interested to find out whether these cells originally would use N-acetylcysteine directly. And this paper was published nearly 11 years ago, and it shows from the depleted form here that you get a dose-dependent increase in glutathione in the cell as you increase the dose. And the top dose here is 1 millimolar. And the important thing to think about here is this is the normal level of glutathione in these cells. And this is like 50 micromolar, 100 micromolar N-acetylcysteine directly on the cells in the medium. It's the only sulfur source. There is no other sulfur source here. So this is not too fancy, and it's certainly not, it doesn't relate to the kinds of concentration. This area here is what you might expect from an infusion of 200 milligrams of N-acetylcysteine in the circulation, 25 to 50 micromolar peaking. So in this area here. So the endothelial cells in this case are not able to use N-acetylcysteine effectively. They can, and there is a deacetylase, but it's not anywhere near the kind of effectivity mole for mole sulfur atom that you would see with cysteine. Okay, that's the important thing to take home here. Interesting, I don't show a slide here, but glutathione, extracellular glutathione in these cells was also utilized to synthesize intracellular glutathione, or rather to support intracellular glutathione, but it was at very high concentrations and was not dependent on synthesis. BSO had no effect. So the carrier there, or how it gets in, one would like to debate that, but it's not physiologically relevant. So
this transpeptidase method?
Gamma GT.
Yeah, you don't think that...
Well, I tried gamma GT in the endothelial cells, and blockers, and it did nothing. So, and that's been a kind of an issue for many years, particularly from Meister, what the role of gamma GT was in cells. The endothelial cells, interestingly, and I don't show you data here, the mechanism that they pick up cysteine from the circulation, there's a classic carrier called the Xe carrier. However, the endothelial cells also utilize gamma GT to pick up cysteine. And we have a paper on that, but I'm not showing data here. So there are a number of mechanisms that they use to pick up cysteine at the optimal concentration of 25 to 40 micromolar from the medium.
So glutathione, you think, is not getting in by GGT, but it's getting in by...
However, but this was done at very high millimolar concentrations, not by resynthesis. No, no, no. Not in these cells, but I'll show you data in smooth muscle cells and skeletal muscle cells where the resynthesis scenario is in fact a matter of course to think about. But in the endothelial cells, no. And only at millimolar concentrations.
So you think it's getting in as glutathione, just getting in?
But it's not physiologically relevant. Sure. So the conclusion is that endothelial cells utilize, and I didn't show you the data for cysteine, but cysteine and cysteine quite equally. And you could argue, when I squeeze cysteine in the medium, it oxidizes to cysteine and gets used as cysteine. Well, either way, the curves weren't exactly identical, but this is a good precursor as well. Over the short time period of an hour, for instance, the kinetics were very, very similar. So these are the preferred substrates, of course. You would expect that. I didn't show you the data, but these cells do not use methionine at all. You can pour methionine on these cells from 10 to 1 micromolar to 1 millimolar, and there is not the slightest resynthesis of glutathione in the cells. So these do not contain all the wonderful machinery that we'll hear about tomorrow. They can use glutathione at millimolar levels in a BSO insensitive manner, and they do have a deacetylase with specificity for NAC, but it seems a relatively poor substrate on a mole-to-mole sulfur basis. Now, just a comment here on the mechanism by which NAC protects the endothelium in the studies with hyperbaric oxygen. It appears then that NAC-induced endothelial protection in hyperbaric oxygen therapy by infusion, as it was given by infusion, and inflammation will hop over for the moment, is probably due to direct scavenging. Now, I also said that N-acetylcysteine is a poor scavenger for hydrogen peroxide, but for hydroxyl radical, peroxynitrite, and other kinds of very reactive intermediates, yes. Because of the poor substrate supply of sulfur for glutathione biosynthesis by this molecule, I consider it to be a direct action. And in fact, you infuse D-N-acetylcysteine into these models and these patients, you get the same effect. So deacetylation has no impact whatsoever on endothelial protection. That's the acid test in this case. The oral administration of NAC, which has a bioavailability of 3 to 5% per se of the molecule, but it is a precursor supplier of cysteine, cysteine, glutathione, and all the other goodies, the endogenous molecules, probably then would function through the systemic supply of cysteine, cysteine, glutathione in its effects on the pulmonary vascular bed endothelium. And there are models, animal models, showing that gavage of N-acetylcysteine will produce protective effects on hyperbaric oxygen. This has not been done in patients. But the effects must be due, per se, to the metabolites that are resulting from N-acetylcysteine on first pass in the gut.
Can you explain? I'm still not quite following. So oral NAC, you say, what does it mean, 3 to 5% bioavailable per se?
As the substance N-acetylcysteine, that's what I'm saying. In the circulation.
Not in the endothelium, not in the...
No, in the circulation where you measure it. It's a pharmacokinetic parameter, bioavailability, where you measure it in the central compartment. 3 to 5% per se, which is the important word here, okay, for itself.
But it gets broken down to cysteine to...
Yeah, so therefore the metabolites are important here.
Yeah, in the pulmonary.
On the gut, in the gut, on the first pass through the gut, you then supply the materials into the circulation, and as they go around the circulation, the endothelium picks it up as cysteine and cysteine, glutathione if that's produced as well. So, but that's a fairly poor reaction. So this is trying to explain, based on precursor specificity studies, how N-acetylcysteine might function in this kind of model, using this basic cell biological approach.
Half-life data in terms of oral to gut to blood, in terms of N-acetylcysteine?
There are fairly good data, clinical as a pharmacokinetic data on blood levels or plasma levels of the free, the oxidized form, protein-bound form, following oral dosing. Yes, but the plasma levels of the compound are very, very low after oral dosing. There's a high first pass in the gut wall, which is giving you the low bioavailability. But that makes no difference. What is tumbling out of the gut wall is cysteine into the circulation, and then that is going around the circulation and serving as a natural precursor, as it should be. The trains are running along the normal endogenous tracks.
Ian, is that number a rat number or a human number?
It's a human number.
And what about, I'll say, the functional bioavailability in other substances like cysteine, like glutathione? How much of NAC gets in if you give radioactive NAC?
Well, in the original studies done by the Italian company Infasam, they worked with radioactivity, and they gave S35 labeled NAC, and they measured the bioavailability of the radioactivity to the systemic circulation of 99%, of course. And they actually didn't look at the distribution in the metabolites. And to my knowledge, there has never been a radioactivity study done in humans looking at how much of the mole dose of sulfur ends up in liver glutathione, circulated glutathione, circulated cysteine. It's a difficult experiment to perform. Nobody's prepared to make S35 NAC anymore for you.
Yeah. I think all of these questions are a little bit questioning the sort of interpretation that you're pushing. I mean, I thought that NAC went through the stomach into the intestine, and there it got broken down, it got deacetylated rapidly, but going into the liver particularly, not in the general.
If you look in the, when we did the when we did the experiments first, looking at the mechanism behind the first pass, in rat, we isolated an intestinal segment. We squirted it directly into the intestinal segment, and then we cannulated the porta cava, and we measured exactly what came out into the porta caval circulation. So this was before the liver, if you understand what I'm saying.
Yeah.
And there was absolutely no NAC coming out of the gut wall.
Right. Okay. So it gets broken down by the gut. I mean, it gets deacetylated by the gut, and it's going, and it's already in the vena
porta cava. That's right.
I mean, so it's the vein going into
Well, I'm not
the liver.
contesting that. I'm not
So
contesting.
it's all going into the liver. It's not going into the circulation.
Well, it's going into the first pass into the circulation past the liver, yes.
Well,
So
in the liver, it's probably going. If there's a shortage of glutathione, it's probably all going into glutathione.
But Ian, when you do that, what percentage of the NAC actually went through? You're saying that was 99% of the NAC that you put into the segment actually came out the other end as cysteine?
cysteine, sulfite,
Right.
which is an important molecule to
Yeah,
think
I just
about,
meant as
glutathione.
So virtually all of it was processed. You didn't lose
Exactly.
much in the
No,
gut.
it's processed in the gut, and it all enters the circulation in different metabolic forms. And this is what I'm saying here. Probably functions through systemic supply of cysteine, cysteine, and glutathione, its primary metabolites, on systemic circulation.
What you're saying is the first pass effect through the liver is not very great. Is that
Well, what you would then expect is that the liver would then extract whatever it needs in the form of cysteine or cysteine.
But the liver does serve as a storage organ, at least a short-term storage organ for cysteine, in that the glutathione level in the liver varies dramatically in association with eating.
Sure. But if you don't have well, that is going to occur for you on the way through the liver. Yes, exactly. Well, I'm not contesting that whatsoever. All I'm saying is that in essence, the therapy of pulmonary oxygen tension, high oxygen tension with N-acetylcysteine intravenously, it was not understood how it protected the endothelium. So based on amino acid precursor specificity of uptake and studies with NAC for the first time on specific cell types other than hepatocytes, one could glean that probably in the infusion a direct scavenging effect was more important than supporting glutathione biosynthesis during the acute phase. Because if you give DNAC, you got the same result. Okay. So let's go on from that one to the next case. Now this is a case to try and illustrate something even more subtle. And this is how cell types cooperate with each other in solid tissues, passing raw materials from one to the other. And this is a case in the communication between vascular smooth muscles and vascular endothelial cells, in how they react to each other, being around each other, and how they pass sulfur amino acids from one to the other. So there is an interest in understanding how glutathione, particularly in smooth muscle cells, with respect to NO metabolism and so on and so forth, is regulated, and there are some instances where smooth muscle cell glutathione has been shown to be drastically affected by in hypertension and inflammatory conditions. Now, again, the same question: which sulfur precursors do vascular smooth muscle cells use to synthesize glutathione? At the point of doing this, nobody had really looked at this properly. It's a simple question. The question then arises, because the vascular endothelial cells lie under the vascular smooth muscle cells lie under the endothelial cells, and the endothelial cells are those that are exposed to the circulation, to the raw materials. And we've already studied endothelial cells and know what they like to use and so on and so forth. How do they interact with each other? Particularly, what is the role of the endothelium in controlling passage to the smooth muscle cells? And to do this, we actually built a method for isolating smooth muscle cells from the same vein that we isolate the endothelial cells from the same individual, and then culturing them separately and then putting them back into co-culture on filters, making small model blood vessel walls, if you like, syngenetically. But the first question arises, what do they use? Well, it's quite clear here that these cells, again, we deplete them of glutathione, and then we add back certain things. And here we can see this is cysteine being added back at increasing concentration. That's 5. That's the normal level of glutathione in these cells, about 22 nanomole per milligram protein. We increase the dose of cysteine to 10 micromolar and 50 micromolar. Now then, this is 5 and 10 micromolar. This was taking 25 and 50 to do this with endothelial cells. So these cells react to lower concentrations of cysteine than do the endothelial brothers on top of them in the normal situation. This is methionine. This is 1 millimolar methionine. Again, these cells are fairly refractory to methionine, but you can get some tricks to be played here. But this is by a long shadow of doubt not interesting at all to these cells as a precursor. As a matter of interest, cysteine, again, is also useful. This is glutathione. I just present this just to show you the different situation with smooth muscle cells and glutathione as opposed to endothelial cells. If you add 25 micromolar, 100 micromolar, and 1 millimolar glutathione to these cells, they use, so that's the normal level, and the arrows have moved. The normal level you see here, we resynthesize glutathione with 100 micromolar external glutathione. We resynthesize a normal complement of glutathione within 6 hours. That's quite fast. And this is the situation here when you do the same in the presence of BSO. So you get an initial rise, which seems not to be affected within the first 30 minutes or so here, or an hour. But then you start to have a drastic effect on glutathione biosynthesis. So this uptake here, this resupportive synthesis, seems to be dependent upon internal glutathione biosynthesis. So in some way that glutathione is taken up and broken down. Now whether this is gamma GT or not, we'll have to make sure. We'll have to do the experiments. But this is the acid test here. So this is a different situation to endothelial cells. These guys will use extracellular glutathione in a BSO-dependent manner. Now then, you remember that endothelial cells were pretty poor at using N-acetylcysteine. Now these are the vascular smooth muscle cells from the same vessel that lie underneath the endothelial cells using N-acetylcysteine. 25 micromolar, 100 micromolar, 250, and 1 millimolar. And that's the normal level of the cells, in the cells. It's not exactly stunning, but this is a better cell type for using N-acetylcysteine. Now, it may be semantic because in the circulation we don't have that. And it's certainly, if the endothelial cell sees N-acetylcysteine, it certainly is not going to survive over the first metabolic layer. But it's interesting to see that NAC is a precursor. 25 micromolar is pretty poor, again. And this might be in and around the area here that you might sustain in the circulation following an infusion of NAC by standard regimes, in Tylenol treatment, for instance. Now, this is the important experiment. And note the different scales here. What we've done here is that we've grown the smooth muscle cells and the endothelial cells on either side of a permeable fixed support. Now, these transwell supports are used to study transport between one side and the other. We have endothelial cells on the luminal side, if you like, and smooth muscle cells on the opposite side. And we then deplete those cells of glutathione, both of them together, in the same manner. We then feed back either cysteine, we've used cysteine or glutathione at these concentrations on the endothelial side, and seen how the smooth muscle cell glutathione repletes underneath. And we've done the control experiments where you do that without an endothelial cell layer in between. So it's just the smooth muscle cell. And we can see here, this is just smooth muscle cells exposed to cysteine. And we see an increase in glutathione, but look here at the axes. This amount of cysteine in cells grown on plastic was up at 25 on the scale here. This is up to 7 maximally. This was repeated many, many times. This tells me something about substrates, substratia, in cell culture work, how they even affect glutathione metabolism, which is an important point people forget. When you put an ensuing smooth muscle endothelial cell layer in between the access of cysteine to the smooth muscle cells, you see the endothelial layer drastically restricts the resynthesis of glutathione in the smooth muscle cell. This is the expression of maybe the normal situation, in that the endothelial cell is the gatekeeper and allowing things to get through. And this is a concept which is not thought about very much in manipulation of glutathione in solid tissues. The equivalents have to get to the cells that are affected over multiple cell layers. And as you go along, each will have its effect on the kinetics and the supply.
Do you have any reason for, is there any data at all concerning other types of endothelial cells, like the lung, the lung epithelial?
Endothelial cells. Yeah, we've done pulmonary arterial endothelial cells. We've also done aortic, and they were from capillary.
Are they similar or
Yeah,
very different?
they're similar. In the aortic endothelial cells are quite similar in their spectrum of what they like to use to synthesize glutathione. We've tried 3 cell types. I just showed you one of them. These are the easiest to get. They're,
We're asking a lot of questions.
that's right. This is glutathione doing the same in the absence of endothelial cells, and when you put an endothelial cell layer in between, again, the cells are acting as gatekeepers. Now, this brings to mind some pretty important questions about what is the normal level of glutathione in an intact tissue, in a cell type, in an intact tissue. So the conclusions from this study are, the specific conclusions, that vascular smooth muscle cells utilize cysteine, cysteine, and glutathione, but not methionine for intracellular glutathione. It's somewhat similar to the endothelial cell brother lying on top of it. Endothelial cells seem to control the flow of precursors from the circulation, perhaps by active transport mechanisms. And we ruled out gap junctional communication between the cells, because we had a selective blocker of that in the myoendothelial gap junction situation, TNF-alpha. Had no effect at all. So we feel that the cells are actually redox cycling cysteine equivalents at the intermap between the cell surfaces. Now this concept, Dean will back me up here, redox cycling over the plasma membrane of the cell, providing equivalents to go to the next cell. This is an important regulatory area which we should understand more about. Vascular smooth muscle cells do possess an N-deacetylase, but NAC is a lazy precursor, relatively, at the concentrations that may be even pharmacologically relevant for the circulation following infusion. And it doesn't contribute directly to smooth muscle cell glutathione per se, probably following oral administration. That's straightforward and obvious, and may not even during intravenous administration due to endothelial cell-specific deacetylation. Now, we haven't done that. That's a speculation. But this idea and concept of having to understand how cells talk to each other with sulfur amino acid precursors is an important one to consider in solid tissues, and even in circulatory cells, B cells, T cells talking to each other, and so on and so forth. And this doesn't affect N-acetylcysteine having indirect effects, though. General, the relevance of concept of cell-cell communication in systemic tissue distribution is important to think about in solid tissues. And this is also something that's important here, that the role of the substratium controlling glutathione synthesis in these cell types. Therefore, I ask the question, what is the normal level of glutathione in these cells in vivo? I have no idea, and this is a problem, that we do not know in a solid tissue what the normal levels of glutathione are often. Now, case 3, and this is a little bit more clinical. This is skeletal muscle cell glutathione being depleted in a systemic trauma, post-operative shock syndrome and ICU patients, and also in extreme physical activity. Which sulfur amino acids do skeletal muscle cells use to synthesize glutathione? It's the same question you saw before. But interestingly here, because skeletal muscle is a highly differentiated cell type, the myotubes are highly differentiated and are the bulk of the tissue. The important question arises, are there differences in glutathione synthesis characteristics between undifferentiated or fairly undifferentiated myoblasts and the myotubes? This is an important question to address when you're trying to attack the problem of replenishment in muscle. This is just the characteristics of the patients in the study. This was published a couple of years ago, Critical Care Medicine, so it's a more recent study. And there's just a variety of reasons why they're lying in ICU. And these patients were pair-matched as well as it went with normal controls for the studies. And this is the data. It slipped down a wee bit. Basically showing that in the traumatic situation in ICU patients, you get about a 50% loss of glutathione very quickly in the patients. And this is within 24 to 36 hours of being admitted for a traumatic injury. And this is the total glutathione, the low molecular weight glutathione pool, if you like, expressed as glutathione and GSH. You see the same kinds of significant drops in glutathione in the skeletal muscle. It's vastus lateralis biopsies that are taken. And this is just an expression of some tabulated data, and all I want you to look at is the significant values here. And we can see here glutathione is affected, drops by 50% nearly. Interestingly, and this is something that I think Lee will be happy to see this, in fact, that reflects rather quickly in protein glutathione mixed disulfides. So you get a similar reflection in the ratio of how much is bound to protein in these cells, in the biopsies. Yeah, you're getting a decrease because you're decreasing the glutathione content of the cell. So there really isn't an oxidative stress in here. It's just the cell is, as the myotubes are depleting from the reduced glutathione. Interestingly here, you see the reflex in the systemic circulation, that you increase the circulatory levels of free glutathione in these patients. So the muscles are emptying into the circulation their glutathione, and that glutathione is being made more bioavailable to the systemic circulation. Now, whether the muscle, like the liver, functions as a reservoir of glutathione is a bone of contention, which we should consider. And it's interesting to note that this decrease in glutathione, total glutathione in the muscle, is that which reflects the quite well-known drop in glutamine concentration in the muscle, which was always been the focus of trauma, in amino acids in trauma in the muscle. But glutathione we added to the list as well. And we're interested to do something about this. So we take human skeletal myoblasts. And now these are grown not to confluency, they're proliferating, they're undifferentiated. And we deplete them of glutathione, and we do the kinds of manipulatory experiments you saw before. And this is just the medium, the control medium, causing resynthesis of glutathione, and you add various things back here. And the take-home message is that this is the normal level. Cysteine is very good, as you'd expect. Note no overshoot here. So these cells are not like endothelial cells. They stop the synthesis of glutathione before they get an overshoot. Cysteine is pretty good, but note the difference. There is a clear difference, and this is 50 micromolar cysteine, 25 micromolar cysteine. This is N-acetylcysteine, pretty good, linear increase. This is glutathione. This is 100 micromolar glutathione, and we've shown that's BSO sensitive again. This is methionine, absolutely flat. So these cells will not use methionine, the myoblasts.
Is because it's not converted to SAM is already saturated.
Well,
the methionine adenylyl transferase enzyme, the KM is
either
saturated.
it lacks the ability to do that, or there's no requirement. But here you have a radical loss of sulfur from these cells. Yes, we're agreed. They're at this point, okay? So they require to resynthesize glutathione. All I'm saying is that they cannot utilize methionine under these conditions.
What are the methionine levels, the basal methionine levels? They're not methionine depleted, are they?
In these cells?
Are they methionine?
Well, they've been put on a methionine-free medium for 24 hours. Yeah, and this is the point. The medium actually doesn't contain any methionine, any glutathione, any cysteine or cysteine. Okay? And that's been the case all the way through. Now, these are cells that have been differentiated for 5 days on 2% serum. And all the markers of differentiation are measured. And these cells are multinucleated myotubes. So you've had fusion of myoblasts together. This is what happens in the muscle. The growing myotube grows bigger because the myoblast fuses and donates its nucleus, and you get multinucleated cells. Now then, this is the same experiment done on the same cells, but only differentiated with low serum. Well, they're differentiated, but it's the same cell batch as the one you saw before. Now, this is the medium, okay, causing resynthesis. That's the normal level. This is cysteine at 25 micromolar, which in the undifferentiated cells was very effective over the short period of time. We were up here at this level after an hour to 2 to 3 hours. We were up here. In this case, the differentiated cells kind of look at cysteine and are kind of uninterested. But it will support resynthesis. But it's different. It's very different to the myoblast.
Why, that's not the medium without the sulfur amino acid?
You add cysteine into it.
Okay, well then how can the medium without any cysteine...
That's the control medium. No, that's the control medium.
That's control...
Control growth medium.
Oh, control growth medium. So it has... Does this have cysteine or cysteine?
It has all the goodies in it. So whatever it's using, I'm just showing you that the cells respond to a medium here. They respond quite normally to their growth medium, as they always do. This is the reference point.
That must contain cysteine or cysteine.
Yeah. Well, whatever's doing that, who knows? That's not important for me. This is the important lines, the rest of them, where I only have one sulfur amino acid precursor. Okay?
But you want the concentrations to be roughly the same.
Sure, I've always used the same concentrations in all of these experiments, just simple illustrated.
In the complete medium, 300 micromolar cysteine?
You have 40 micromolar cysteine. 40 micromolar cysteine. They put...
What are you adding a cysteine to?
25 micromolar. I mean, it's fairly saturated. 50 micromolar cysteine, that's non-physiological. Glutathione at 100 micromolar, non-physiological. But these are concentrations used to probe the biochemistry, not always to be relevant, strictly relevant.
And you're giving me the figures for the complete meat, 199 complete.
Yeah, there's about 40 micromolar cysteine in there. One.
The point is that you want to add back the individual ones in roughly the same amounts as they are in the complete solution, it seems to me.
Well, you are doing that. You are, in fact, you're overkill with a lot of these substances. Cysteine, you are relatively matched to what you see in the medium and what you see in circulation. But what this cell type sees in its intima, in its extracellular environment, who knows? So that's a semantic argument. The important thing here, and cysteine now...
So NAC is the...
Hold on, I'm coming to NAC. I'm coming to NAC. This is cysteine up here, which all of a sudden now becomes a superior amino acid precursor than cysteine at 50 micromolar. This is the switched situation from the myoblast.
Is this possibly, I mean, you studied this for the, just uptake of the cysteine? They have different pumps for...
Well, that's the next series of experiments. All I'm doing is characterizing. I did these experiments 3 weeks ago.
Oh, I thought this was years ago.
No, this is new stuff now with the actual cell system.
This question is relevant because now you're making a value judgment that one's better than the other, and you're using different concentrations. So
when I compare myoblasts with myotubes internally.
You just compared cysteine with cysteine. One is at 25 micromolar, and the other is at 50 micromolar.
Yeah, because
unless I see a phenomenon of dose response curves, I don't know what that means.
Yeah, in this case, sure, I understand what you're saying, but I just want to compare myoblasts and myotubes, okay? The dose-response curves will show you what they show you. But I'm keeping the concentrations at a steady state here to compare the one cell type to the other, just to give you the illustration. The differentiation process actually changes the specificity of what you're looking at.
So cysteine was at 25 micromolar with the myoblast and with the myoblast.
Yeah, because cysteine, because he's figuring that cysteine is fusion figured two times.
Now,
but the point is then that the proliferating cells, or the non-differentiated cells, liked cysteine, whereas these like cysteine.
yeah, that's the first difference. Okay? The second, this is NAC, fairly unaltered in comparison to the myoblasts. Little lag phase here, which is interesting. This has to be... Oh, that's repeated. This is, the bars are on here. We've done this twice now, but this is like 3 internal repeats on the same day. and the curves come out fairly similar. But this lag phase in the myotubes seems to be quite important.
Would it be the deacetylation?
That's right, exactly. It takes a little bit of time to build up the cysteine here. This is methionine now. Methionine actually is starting to work in these cells. So unlike the myoblasts in the same situation, the myotubes will actually use methionine to a relatively poor extent, but they will actually trickle in glutathione, with methionine as the sole sulfur source. There's a difference there again. This is glutathione. These cells do not use glutathione extracellularly, whereas the myoblast did. And the line you don't see underneath it, that's the glutathione monoethyl ester. You don't see it, it's a bit light here. It's a fairly poor precursor, but it is utilized. There is a deesterification in there, and that's the diethyl ester. It's flat down here. It's not absolutely used, not whatsoever. So I just want to illustrate to you that the state of differentiation of the cell in the model system can affect the uptake characteristics of the amino acids that you're looking at. And it's an important concept to think about. So in comparison, differentiation of human skeletal muscle cells switches the efficacy of use of cysteine and cysteine. And I don't know whether it's to do with the carrier phenomenon or whatever. We can study that, okay? It upregulates the ability to utilize methionine. And this is the first cell type out of the liver in my hands that I've ever seen use methionine to synthesize glutathione. It downregulates the use of extracellular glutathione quite clearly. So whatever is carrying in the glutathione, it's probably gamma GT. Then that does not work in the differentiated myoblast. It doesn't affect the ability to utilize NAC. So direct intramuscular injections of NAC, who knows? Conclusions, specific. In the treatment of muscle glutathione loss, systemic precursor supply of sulfur amino acids to traumatized patients, you might think about using the reduced amino acid cysteine, methionine and NAC, perhaps in combination. Now in Sweden, these are not generally used in parenteral nutrition in these conditions, and certainly not in infusions in ICU. But that brings about problems when you're using reduced thiols. The solutions have to be prepared fresh and administered with some kind of precautions for oxidation if you're going to optimize delivery. But of course, the vascular endothelial cells in the muscle bed will do their bit for you first. So perhaps all of this is irrelevant. We don't know. But in general, I would say that the state of differentiation of a cell type can drastically affect which precursors are utilized. So that has to be considered when you are going to clinically manipulate a solid tissue glutathione level. So lessons that can be learned are that match the choice of precursor to optimize the delivery of cysteine equivalents to the site of requirement. Obvious, if you can do it. But the kinds of basic studies studying these kind of parameters have to be done for you to do that. So you're based both on pharmacokinetic considerations, which is the normal thing that you would think about, and also the uptake characteristics, the target cell type involved. There's a lot more to be learned about the normal shuffling of amino acids in the body, sulfur-containing amino acids, between cells, between the circulatory pool and the tissues. We don't know enough about that yet. And I think this is important here, that novel compounds which improve the delivery, we already have one, N-acetylcysteine, but novel compounds must be developed. Drug industry has kind of forgotten this and given up. They are not spending a lot of time and money developing compounds for improving cysteine delivery at the moment.
But why do you need another compound when NAC works so well?
Well, it works well for some things, but not for others. All I'm saying is that there must be ways of optimizing the local delivery of a cysteine equivalent further than NAC. I'm saying that's one answer. But, for instance, hanging on a handle for an amino acid carrier that has nothing to do with sulfur amino acids. In the drug industry, we try to do this. We even hung on dipeptides to capitalize on dipeptide transport mechanisms that would deliver NAC over the systemic circulatory wall to the tissue. Then it would then be processed as normal, as NAC, to increase the bioavailability of the compound as well, perorally, so that it didn't undergo the massive first pass in the gut, to see if we could then supply a thiol compound systemically from an oral preparation. We made dipeptide derivatives of NAC and tried them out in animal models, and you got some success, but it was dropped. They got tired with it. And why? Yep.
That's because there isn't any money in it.
Right, exactly. Well, the indications are fairly big time, some of them, but they're not big time enough to continue developing these compounds. As anti-inflammatory agents, they offered no benefit over standard steroid therapy, for instance.
What about OTC?
Yeah.
Novel kind of cysteine delivery.
But it has its problems as well, toxicologically. Yeah.
The world gave up the company.
Well, you know, the lessons that we learned from N-acetylcysteine, which I agree, and I'm not banging on the desk here and saying that, you know, we need other things because NAC is a lot of crap. In the absence of a will to develop novel compounds at present, N-acetylcysteine remains the most promising pharmacological cysteine donor for clinical manipulation. Absolutely. I am fully in agreement with that. It doesn't mean to say that through making this concept more kosher to the literature, to clinical practice, to anybody you want, it should be able to stimulate interest in this area at the pharmaceutical industry level to go back in and have another try, because I don't think we're clever enough yet. And the more we learn about endogenous amino acid disposition, and the more we learn about NAC as the first example, if you like, the more we will stimulate development in industry. But it's a delicate process.
Can I raise another point which you haven't considered at all, we haven't discussed, namely the intracellular localization of glutathione, which can be manipulated also. And you know, we published a paper, somebody in our lab who's not here, published a paper showing that you could move glutathione from the cytosol to the nucleus by giving BCL2, the anti-apoptotic molecule. And so apoptosis, you know, is determined very much by where glutathione is, if it's in the mitochondria or in the nucleus or in the cytosol. You know, that's something that could...
Well, if you look, I mean, turn it around the other direction. One of the ways of depleting glutathione from lymphocytes is to hit them with FAS. FAS, yeah? And they just empty, bang. So glutathione has a tight relationship to apoptosis. Absolutely correct. And if... But if you disturb the glutathione redox balance in the mitochondria, for instance, through oxidative processes, you've got permeability transition, jiggery quick, and you've got caspase activation. So it is important in the mitochondria. In the nucleus, there is very little known about what regulates the nuclear pool of glutathione.
BCL2 does.
Is one of the components which does, under certain conditions, in certain cell types. Exactly. But the nuclear pore, how is that selected to glutathione? Nobody knows if there's a gradient, even. The original papers done in our laboratory, beginning of the 1990s, were all artifacts, unfortunately. The PNAS paper produced by Bellomo and company, using bromobiamine, using chlorobiamine, in fact, were artifacts. The chlorobiamine adduct was pumped into the nucleus. So there's a lot to be learned there, and we'll give that one a good hammering for the next couple of years. Yeah. That's the end of the talk, by the way.
Will dosages of NAC be given to achieve levels in the tissue of NAC that gave you those glutathione replenishment effects?
The point is, the subtle point here is that when you give 200 milligrams orally, which is a small dose, which is what was indicated in therapy of bronchitis in Europe during the 80s, times 4 over the 24-hour period, you measure sub-micromolar levels of free NAC in the circulation. But you measure, you know, an increase in glutathione, increase in release of cysteine into the circulation, and other things. Yeah, sure. But it's not NAC itself. That's the subtle thing to get over.
It hasn't been measured for, let's say, a dosage of 2 grams.
Now, we have no kinetics on high dose. That's a big hole, yeah. Yeah.
Going back quickly to your work with the peptides, what was the pharmacokinetics of the peptide moving through the gut, and then, I mean, was it like so many small peptides, it's just lost in the bile?
No, they were I'm not really at liberty to talk what the structures were, but they were engineered to. There were a number of peptide carriers that were at the beginning of the 90s were cloned that were enterospecific, and they were engineered to fit those peptide carriers. So they weren't straight off dipeptides either. They were slightly modified to improve the uptake on the dipeptide carriers in the gut wall, and it's been now improved to some extent. We now know there are a number of these dipeptide carriers, or small peptide carriers. But then the project was dropped for various reasons. But it was a clever way of getting past this first pass effect in the gut wall, which is something we haven't discussed in our discussions with NAC. Get it over the first hurdle, provide something pharmacological that you can study in the central compartment, then you can start to treat it like a normal drug, rather than the perfect drug it is, which is getting lost in endogenous metabolism. It's a perfect drug.
Well, from that point of view, is it realistic to think about getting back to Len's point, can you have a repository of a peptide, like a genetically engineered peptide, that basically could be sequestered in some location in the cell, that actually would provide your system act as a system donor?
The theory was, yeah, that's the theory we were working on, that in some way we could manipulate, yeah, but in some way, yeah, well, in terms of inside the cell, engineer it. Nice idea. Why not?
GSH is something that's not often addressed, but it's quite important. I've been doing some recent experiments with BCL2, and it appears that subsequent to mitochondrial GSH depletion, you can circumvent the protective effects of BCL2. Now, whether that's mitochondrial, whether it's nuclear, it appears that the expression of BCL2 after BSO treatment long-term is downregulated, and you can actually knock out the protection conferred by BCL2. Mitochondrial GSH is probably really important for BCL2's anti-apoptosis.
Yeah, absolutely. I don't disagree with you whatsoever. In fact, Sten has people doing that as well in the laboratory. More than that, I will not say. That's the way it is. I'm not involved in that, but it's a hot point. Particularly when you think of BCL2's role in mitochondrial function, particularly during the megapore formation, and also in the new stuff with cardiolipin. There may well be interactions there that we don't understand. Also with heat shock proteins.
Yeah, okay. The interaction of BCL2 with the MPT is pretty controversial in actual fact. Some people say it's an antioxidant, others say that it blocks the MPT and prevents cytochrome C release, so it prevents apoptosis that way.
Well, it depends if you feel that permeability transition, or it depends if you feel that the loss of cytochrome C is due to swelling or due to pore, or whichever theory you believe there.
So, with protonophore, depolarize them. I've shown that they can repolarize. And the belief is that depolarized cells undergo MPT as a consequence of depolarization. But I've shown that the cells actually repolarize after a certain period of time. So that in itself is not a death signal per se.
Okay, we're getting out of scope
yeah,
of the conversation here. I'll take that up with you afterwards.
Well, this might be a good time to thank you very much for giving us a presentation.
Thank you.